Okay, welcome everyone. Thank you for joining us this evening. We're grateful that you took some time out of your schedules to learn a bit about some of the amazing work being done in the John F. Hardesty, MD, Department of Ophthalmology and Visual Sciences at Washington University School of Medicine. My name is Kevin Largent, and I'm the Senior Director of Advancement at Washington University School of Medicine, and I work closely with the Hardesty Department of Ophthalmology. I've been lucky enough to meet several of you who are here tonight, and it's really good to see you again. A couple of housekeeping announcements before we get started with the presentation. Everyone's screen should be set to the speaker view setting. This is done to maximize your experience tonight, so we recommend you keep the setting as is. Another aspect of tonight, we hope tonight will be interactive, but with the number of people that we have over Zoom, that can be difficult. So what we've done is we've enabled the Q&A function, which is an icon at the bottom of your screen, should be close to the center. Please submit all questions and comments through that function. We will take some time throughout the presentation to answer a few questions. Then we also have a few minutes allocated toward the end of the presentation to answer as many questions as we can this evening. One other aspect of the question and answer function I'd like to point out is we would like you to focus your questions on content that is related to Dr. Siegfried's presentation or generally broad concepts within the glaucoma sphere. Please do avoid sharing any personal health information or asking Dr. Siegfried for any medical advice during tonight's presentation. Now, it is my pleasure to introduce Dr. Todd Margolis. Dr. Margolis is the Allan A. and Edith Wolfe Distinguished Professor of Ophthalmology and Chairman of the John F. Hardesty, MD, Department of Ophthalmology and Visual Sciences. Dr. Margolis has led the department since January of 2014, has provided tremendous leadership in education, research, and clinical care, which are the three key pillars that form the foundation of our mission. Dr. Margolis?
Thanks, Kevin. Good evening, everybody. Thanks for taking the time to be with us tonight. I'm Todd Margolis. Tonight is the first of a series of talks that we've planned for this year. Talks aimed at educating the community about common ocular diseases, including recent understanding of the causes of these diseases, as well as the latest therapies. With residents, fellows, optometrists, ophthalmologists, and scientists, our department at Washington University is one of the leading academic departments of ophthalmology in the country. We teach, carry out groundbreaking research, and have 65 clinicians providing care in 11 locations, including the VA and Shriners hospitals. Many of our clinicians are also accomplished scientists, and thus our tagline, cutting edge medical and surgical care by the nation's leading clinician scientists. One of our most accomplished clinician scientists is Dr. Carla Siegfried, an expert in glaucoma, who will be speaking to you tonight.
Thank you for that kind introduction, and good evening, everybody. Welcome to our inaugural presentation from the Washington University Department of Ophthalmology and Visual Sciences. I'm excited and honored that so many of you are sharing time with us this evening to learn about an important cause of vision loss, glaucoma. Yes, indeed, glaucoma may be quite sneaky as it progresses without symptoms, and once you may begin to notice these changes, it's often more advanced. So let's begin our journey this evening. I always like to begin a presentation with a few objectives and goals, no matter who my audience is. So I challenge you to learn one new idea or concept this evening, just one. I hope that you can increase your understanding of glaucoma and gain important information about glaucoma and public health. And finally, I hope that you spread the word to your friends and family about this important condition. So what is glaucoma? Glaucoma is a group of eye diseases that can cause vision loss and blindness by damaging the optic nerve in the back of your eye. It is not a single disease, and that's very important to understand. The optic nerve, I just want to go over a little bit of anatomy here. The optic nerve is what plugs into the back of the eye. All of the information of vision from the eye is sent down the optic nerve and to the brain, down this pathway. If that pathway is damaged, however, and it is damaged permanently, as in glaucoma, it can result in vision loss. I want to jump now to the front of the eye and just go over again some basic anatomy. The front of the eye is the cornea. And that is a clear window to the front of the eye. And if we wear contact lenses, that's what the contact lens sits on. This area here is a fluid-filled chamber, and it's filled with something called aqueous humor. It is that fluid where it builds up pressure that causes some of the changes that we see in glaucoma. It's important to understand that this fluid is made in the ciliary body and goes through the pupil, which is the hole in the center of the iris, the colored part of the eye, and goes out through the drain in this area called the angle. And in fact, it is an angle that is formed by the cornea and the iris. And that's where this very important structure is in the natural drain called the trabecular meshwork. We'll talk more about that in a little bit. I also want to point out the lens of the eye, because this is also a very, very common condition. When the lens becomes cloudy, we call that a cataract. And so that is a very common surgery that we perform in ophthalmology. I also want to point out that this whole structure here is filled with a gel fluid, and that's called the vitreous. And finally, I want to talk about this film, this wallpaper that covers the back of the eye called the retina. And the retina is really the film that takes the picture, and then that picture information is sent down the optic nerve. The macula is a very specialized part of the retina that takes a picture of the very center vision. So that's your reading vision, that's your recognition of faces. And so patients with macular degeneration have problems with their very central vision. So what about that drainage angle of the eye? Why does pressure build up in the front of the eye? So again, this is a magnified view of what I just mentioned before. Fluid is made here in this structure called the ciliary body, comes through in front of the lens, through the pupil, and into this drainage meshwork, the trabecular meshwork. It then goes on down into other pathways and eventually leads into some small blood vessels and goes into our general circulation. But the trabecular meshwork is thought to be an important part of the cause of glaucoma, in that the pressure is elevated because this structure no longer works normally. In order to see the trabecular meshwork, when we examine patients, you can't look straight on and see it in the eye. You actually have to put a little lens onto the surface of the eye called a gonioscope. And that allows us to use mirrors to see into the drainage angle of the eye. This is also important for some of our treatments into the drainage angle, some of our laser treatments that I'll get into a little bit later. So let's go over some important facts about glaucoma. It is a leading cause of irreversible blindness worldwide. Over 3 million Americans have glaucoma, but only half are aware of their condition. More than 120,000 individuals are blind from glaucoma, accounting for about 10% of all causes of blindness in our country. The suspected cases of glaucoma across the world are over 60 million, and 4.5 million are blind from this disease. It is most commonly seen without any symptoms until late stages, and there's no cure, but early treatment can often stop the damage and protect your vision. In a recent survey about perceptions of glaucoma, 20% of people that were surveyed knew that glaucoma was related to elevated pressure within the eye, but most mistakenly thought that people with glaucoma had symptoms, they could be easily cured, or that this condition did not lead to blindness. 50% of Americans had heard of glaucoma, but weren't sure what it was. Perhaps you're in that group, but perhaps by the end of my discussion this evening, you will have a much better understanding. And blindness ranked third, only after cancer and heart disease, as people's major fear in life. So let's talk about some risk factors for glaucoma. And a risk factor, of course, is something that increases the risk of developing the disease, but doesn't define the condition. And number one is increased eye pressure. Some people think that all increased eye pressure is glaucoma, and that all glaucoma is increased eye pressure. Indeed, it is not part of the definition of glaucoma, but it is the most important risk factor for the condition, and it is also our target for treatment. Today, in 2020, the only treatment that we have for glaucoma is lowering eye pressure. Now you ask, well, what is a normal pressure? What's okay? Well, that's a really complex question, and I don't want to go too deep into it, but I do want to say that the average pressure across the population is about 16. We call high pressure, for a variety of reasons, over 20 or 21. But having a pressure over 20 or 21 does not mean that you have glaucoma or you will get glaucoma. In fact, there are a lot of people who have pressures higher than 20 that will never develop glaucoma. But in the same vein, there are people who have pressures under 20 who will develop glaucoma. And so it is very important to look at not only eye pressure, but the whole eye. And we'll talk about that in a little bit when we get into discussion of diagnosis. Age over 60. Now, we don't call that old anymore. We'll just say age over 60. African Americans or Latinos, however, who are over the age of 40 are at increased risk of glaucoma. Those who have other family members with glaucoma. But it's important to know that many patients with glaucoma don't have any risk factors identified. So thus, again, another reason to call it the sneak thief of sight. So how do we diagnose glaucoma? Well, it's very important to undergo a comprehensive eye exam, including dilation of the pupil. That's when we put drops in the eye that enlarges the pupil so we can see clearly into the back of the eye. Not just a pressure measurement. As I mentioned before, some people have high pressures who don't have glaucoma, and others have low or normal pressures and do develop glaucoma. Unfortunately, less than half of all Americans have a complete eye exam every 2 years. Glaucoma is also recognized by visual field examinations. So the optic nerve is important in not only the center vision, as in the macula, but it's also important to determine peripheral vision. A lot of people think peripheral vision is just vision on the sides, but in fact, in early stages of glaucoma, it's the loss of vision towards the nose, that is the inside part of your vision, that is lost early on. And that outside by the ear is actually the last part of the visual field that is damaged. So unfortunately, or fortunately, the way that we are set up, the other eye compensates for loss of vision towards that inside nose area. And finally, optic nerve imaging, not only an optic nerve exam, but we now have some more sophisticated ways to look at the optic nerve, and we'll talk about that. So this is an image of a visual field report. So a visual field machine presents lights, and the patient pushes the button when they see the light. You can see here these large dark dots. That represents the blind spot, the normal blind spot, which is where the optic nerve plugs into the back of the eye. You can't see in that area where the optic nerve is plugged in, but we can see on all the other areas that are represented in the retina. This is a normal left eye, and this is a normal right eye, given the location of the blind spot. This is a patient with progressive glaucoma. You can see this darkened area here, and that represents an area where the patient did not see the light as it was projected on the screen in front of them. And so this is what we call a nasal step. And that area you can see expands and becomes an arc, an arcuate defect. And finally, it goes on to fill in that area, going very close to the center vision, and then starting to develop defects in the upper part of the visual field. This is a progression of glaucoma. In most cases, this level of progression can take years. It can go very, very slowly. And so it's very, very important that we try to catch it in an early stage before there is damage that extends into the central vision. And here we can see even later stages where it takes much of the visual field. Here on the left is a picture of a healthy, normal optic nerve. And what's so healthy about it is the color, the pink, beautiful color that we see, and this area in the center that's lighter, which actually represents an indentation, or what we call a cup. And that is a small area in the center of this very healthy pink optic nerve. In contrast, we see an optic nerve with very severe glaucoma. And that indentation, that cup, has expanded, enlarged to cover the entire area of the optic nerve. So here we can see the edges of the optic nerve as it plugs into the back of the eye. This is the retina, this orangish color, and you can see these blood vessels here. But here, it's all white, and that the pink area is completely gone. And that indicates that there's been significant damage from glaucoma in this patient. As I mentioned, we have some much more sophisticated ways of evaluating the optic nerve. And it's really helped us to detect early changes as well as detect progression. This is called an OCT, or optical coherence tomography. And basically, it's like an ultrasound, except instead of using sound waves, it uses light waves to tell us what is going on in the optic nerve. And it's measuring the thickness of all that information that's coming in from the retina and going out into the optic nerve. These red areas are areas that, compared to age-matched normal individuals, this patient has thinning of that area, indicating damage from glaucoma. So we classically see in glaucoma thinning of the upper and lower parts of the optic nerve. And we can see some early changes in the left eye as well in this patient. And we can follow that to see if there's further changes, further thinning as time goes by. I want to touch on types of glaucoma. As I mentioned earlier in the description of what the definition of glaucoma is, I said that it's a group of diseases. Well, indeed, we divide them into primary and secondary types of glaucoma. Within primary, the most common, and this represents at least 90% of all glaucoma in the United States, we have open angle glaucoma. There is also a glaucoma type which is on the spectrum of open angle glaucoma, where there are low or normal pressures. And these patients never tend to get higher pressures, and they have some other specific characteristics. We're learning more about this type of glaucoma, which is the most common type in other countries. For example, in Japan, it represents a very large proportion of patients with glaucoma. And there is angle closure glaucoma. We talked about the angle of the eye that's formed where the cornea and the iris meet, and that special drainage tissue, the trabecular meshwork. The angle is open and it appears completely normal as we examine it. However, there are cellular abnormalities in that tissue that don't allow for normal drainage. In contrast, patients with closed angle glaucoma have closure, and so that the fluid cannot get into the trabecular meshwork. There's a variety of causes of angle closure, including as the lens gets larger as we get older, it pushes that iris forward and can close off the drain of the eye. And there are other more specific treatments for angle closure versus open angle glaucoma. And I also want to mention congenital or juvenile glaucoma. And oftentimes these are much more genetically associated, but people can be born with glaucoma, and young children can also acquire glaucoma at an early age or even in young adulthood. And again, these are oftentimes more aggressive diseases, usually treated with surgical therapy. I also want to mention secondary glaucomas, and there's a whole variety. And secondary indicates that there's other causes that lead to glaucoma. So you can have inflammation in the eye, as in uveitic glaucoma. You can have abnormal blood vessels that grow into the drain of the eye, as in people with certain types of diabetic retinopathy. So there's a whole plethora of causes of secondary glaucoma. I want to touch on a case presentation because I think that this illustrates what we do every day when we take care of patients. And this is a 58-year-old African-American female with no known family history of eye disease who noted blurred vision in her right eye for a few months before she came in to see the referring doctor. She thought she needed some new glasses. It had been several years. and she was referred to see us with a possible diagnosis of glaucoma. When she presented, her vision in her right eye was 20/40. And just to give you some perspective as to what 20/40 vision is, it's really pretty good vision. This patient could drive, could pass a driver's test with a vision at the level of 20/40. And in her left eye, it was 20/20. So very functional vision. However, her pressures were markedly elevated. Remember, I mentioned that the average pressure for the population is about 16. Hers was 43 in the right eye and 32 in the left eye. No pain, no symptoms. Nobody could notice that she had elevated pressures. And this elevated. She noticed a little blurred vision. On examination, her angles, as I discussed before, most commonly we see that they're open, and I could certainly see that there was damage to the optic nerve. These were her visual fields on presentation. Very advanced damage affecting her central vision now in the right eye, but she could still see 20/40 through that right eye. And in her left eye, she also had significant visual field loss in the lower part of her field. But here, very normal centrally, and she was able to function with 20/20 vision. Had no idea there was anything wrong with her left eye. So we discussed treatment options, and her perspective was that I now have presented her with a diagnosis of permanent and perhaps progressive vision loss. Lots of fear, tremendous fear of loss of vision, further loss of vision. And she questioned whether she would ever see her grandchildren grow up. I want to turn now to some public health issues, and public health is in the news all the time now regarding COVID, et cetera. And I think we're going to have a lot of public health specialists. I think people in college are going to major in public health, and we're going to have a large group of people who are looking at that. So I want to touch on the economic impact of glaucoma. It accounts for over 10 million visits to physicians each year. The cost to the US government, including Social Security benefits for disability, lost income tax revenues, expenditures in healthcare, $1.5 billion annually. We are well aware of racial disparities in a variety of diseases, including diabetes, hypertension, heart disease, obesity, and glaucoma as well. After cataracts, glaucoma is the leading cause of blindness among African Americans. Blindness is 6 to 8 times more common, 15 times more likely to be visually impaired, and the most common form accounts for 19% of all blindness among African Americans, compared to 6% in Caucasians. Latinos are also at markedly increased risk of open-angle glaucoma. I want to share with you this graph that was published by the National Eye Institute. And this looks at the prevalence rates, that is, how many people developed glaucoma by age. And you can see here at the bottom, age, 40s, 50s, 60s, 70s, and over 80. And how many developed glaucoma, percentages here along this column. You can see the red bar is always higher than the other colors, and those represent African American individuals in the US. Much, much higher prevalence rate of glaucoma all the way through, up to 12% in those over the age of 80. Now we can see even in white patients or Hispanic, we see that there's also a marked increase as age increases, but there's significant disparity to be aware of. So how do we treat glaucoma? Let's change gears a little bit and talk a bit about treatments. We have medications, we have laser treatment, and we have surgery. In terms of medications, eye drops are our mainstay of therapy, which lower pressure. They're instilled once, twice, 3 times a day, depending on the medication, and are very, very effective in many patients. However, there are challenges of cost, side effects, and remembering to take the medications, actually getting the drop in your eye. There are videos of how patients put the drops in their eye and how frequently the drops are missed. Then they run out of the medications, go to the pharmacy to get a refill, and unfortunately, their insurance company will not allow them to get a refill. It's too early, so they may be out of medication for days at a time until the pharmacy allows them to get a refill. So there are many, many challenges with eye drops, but it has been our mainstay of therapy, at least initial therapy, in most patients. I want to introduce just a couple of novel drug delivery methods that we are now working on. And one is something called punctal plugs. So the puncta is that tiny little hole that's towards the inside of your eye, which allows the tears to drain out down into your nose. And that little hole can be filled with a plug, and that plug can be embedded with a medication. And that medication then is slowly released into the tear film. And instead of putting a drop on the eye, the medication comes from this little plug that releases it for an extended period of time. Those are under study. There's nothing approved yet by the FDA, but it's a new way of delivering drug. And another way is through a pellet that's placed inside the eye. And this was actually recently approved by the FDA just a couple of months ago. And this tiny pellet, and you're going to see a lot of coins here in my presentation, because everybody compares the size of something to a coin. So you'll see dimes, nickels, pennies throughout the presentation. And this is a little tiny pellet, and it is placed in the eye, and it sets at the bottom of the eye within the anterior chamber angle. And it sits right next to the trabecular meshwork here. It releases drug for months at a time. And this is a new way of potentially providing medications to patients rather than installation of drops on a daily or multiple times a day basis.
Dr.
So
If
yes.
I can interrupt real quick, we have a couple of questions that I'd like to
Perfect. Great.
both of the questions come from Stacy Ketchum, and the first question is, what is the cause of glaucoma? She said she was permanently told it was genetic. So if the increase in occurrence in certain races based on social factors, or is that genetic?
That's a great question. So when we look at genetics in glaucoma, we have identified in large studies of whole genomes, studies called GWAS studies, or genome-wide association studies. There are several genes, a dozen or so genes that have been associated with glaucoma. But we don't do genetic testing for glaucoma because there's so many that we haven't identified. And if you add all those up on a worldwide basis, it really accounts for less than 10% of all glaucoma, probably a fair amount less than that. That's being generous. So it's not all genetics. And it's an interesting question that you ask about the racial disparities. And we don't understand that yet. I'm going to get into my research, and our research. We're starting to identify some truly genetic causes, but it's very, very complex. We call the cause of glaucoma multifactorial. Basically, that means that we don't understand why some people get glaucoma and some people don't. But that's a great question, and I wish I could answer it better, and hopefully I will in the future.
And if you don't mind, she actually has one other question. I think it's a good one as well. If the medications work by lowering eye pressure, how does it help low pressure glaucoma?
So there was a study back in the early 90s looking at precisely that question. So if you have low pressure, does lowering it more help? And the answer to that question is yes. And this was a large study funded by the National Eye Institute, the normal tension glaucoma study. And indeed, it does. And in 2/3 of patients, you see a stabilization of their glaucoma damage with pressure lowering. So if you can lower the pressure, even in those who have, quote, low pressure or normal pressure into subnormal pressures, you can cease progression of disease as well. Great question. Okay, I'll move on to laser treatment. And laser is a very directed light energy beam. And we've been doing laser treatments for glaucoma for many, many years. When I say many, many years, it's really in the late 70s that the data for the argon laser trabeculoplasty first was presented. We now use a slightly different type of laser called selective laser trabeculoplasty. And the treatment is a little different, and the mechanism is probably a little bit different as well, but the concepts are very similar. This laser energy is directed into those special cells in the drain of the eye, the trabecular meshwork, to help them to work better. They don't poke holes. It's not a mechanical hole punch that increases the fluid flow through that tissue. In fact, it's really more of a chemical reaction or a change in the configuration of those cells that improves the outflow. And this is an image. And again, we would put a lens on the eye with a mirror, so it allows us to direct that laser energy into the drainage area of the eye. It is not focused on any vision part of the eye, so the risk of the procedure is exceedingly low. The benefits, about 75% of people respond with a 20% drop in pressure. We use laser in the spectrum of treatment and can be used early on as initial treatment, but can also be used later on as we add medications. Next, I want to talk about glaucoma surgery. And we divide this now into minimally or microinvasive glaucoma surgery, known as MIGS, as well as more traditional glaucoma surgery. And there is an overlap of when we can use one versus the other, but there's also some important distinctions. Glaucoma, or MIGS procedures rather, are less invasive by definition, with usually faster recovery time, and are also more appropriate for early stage disease when you don't need that subnormal pressure in order to prevent further progression. They help the natural drain work better. Whereas traditional glaucoma surgery is more invasive. Both, however, are performed in the operating room. There is greater risk, but also greater return, which may be appropriate for later stage disease when you need lower pressures. And these procedures make a new drain for the eye. They make a new outflow pathway. So let's talk a little bit about MIGS. And I'm just going to go through a couple of examples. And the first one is an eye stent. And again, here's our little coin and how tiny the eye stent is. It's extremely small. In fact, it's the smallest implant ever placed in a human. And you can see here, this is an image of the drain of the eye. And you can see the iris, and this is the cornea, and where they meet is the angle, and that brown stripe here is where the trabecular meshwork is. And it's like a little snorkel that you see just that end sticking out, and this goes into the canal behind the trabecular meshwork. And it allows a bypass of the tissue of resistance, the trabecular meshwork. The hydrus works in a somewhat similar manner. Again, our nice penny here, except it's over a broader area, and it acts as a stent to stretch that tissue and allow better flow through the trabecular meshwork into that Schlemm's canal, that canal where the meshwork leads to. And it goes over a larger area. This is more 2 to 3 clock hours. And finally, a goniotomy procedure is performed when we actually remove a small strip of the trabecular meshwork, thereby, again, removing that tissue of resistance. The others bypassed it, but this actually removes it and improves the outflow out of the eye. And you can use a variety of different devices to remove that trabecular meshwork. This is actually very important to us in our research because we are studying the trabecular meshwork, and this is a way that we can collect that tissue from patients with glaucoma. Traditional glaucoma surgery, as I mentioned, is redirecting the fluid to the tissues on the outside of the eye. Now, it's still a closed system. It doesn't drip down your face. It's not exposing the inside of the eye to the outer environment. It forms a little blister that we call a bleb. And this is a very traditional procedure called a trabeculectomy, where we make this little trap door out of the white tissue covering the surface of the eye called the sclera. And at the base of that, there's a small hole that allows the fluid that's building up pressure inside the eye to come out into the surface tissues just under the surface and form this blister or bleb where it collects and then is slowly reabsorbed into the tissues. You can put a little stent, this is called an express shunt, into that hole as well. Or, and here's a nice bleb, this is a very large bleb that is hidden underneath the eyelid, and patients really do not feel this. And this is a little noodle that we call, that is the Zen gel stent, that also is another way of forming a bleb. And in patients where they have specific conditions that put them at high risk for scarring, or there has been scarring and failure of a standard filtering procedure, we put a tube in the eye. And this tube shunts the fluid to a plate where the fluid is then again slowly reabsorbed. There's a variety of tube shunts that are out there, and they all have some pluses and minuses. Some have valves within them, some do not. And there is a variety for different glaucoma conditions. So where does the future lie, though? Where can we look? Well, we're always finding new targets, and hopefully that will lead to new medications. But what about stem cells? Is it prime time yet for them? Well, what are stem cells? We hear a lot about them in the news. And basically, stem cells are cells that can grow into a variety of more specific cells. Think about bone marrow. Bone marrow yields white blood cells, red blood cells, and other cells that are circulating in the bloodstream. But how does this relate to glaucoma therapy? Well, we could develop stem cells to rejuvenate the trabecular meshwork, the cells that have been damaged over time, or support structure for the optic nerve where it plugs into the back of the eye, a tissue called the lamina cribrosa, or even those cells in the retina that grow into the optic nerve and send that information on down to the brain. We could protect them from degeneration, or we could even form new cells and regenerate them. But there's no current properly designed clinical trials. And I really want to emphasize that. And now we're hearing a lot of jargon about phase 1 and phase 2 trials with the vaccines. And I want to emphasize that there are just not any current clinical trials studying stem cells for glaucoma right now. There are some patient-funded studies, and I would very clearly steer one against those. You really need very clear preclinical data, which is animal data, before we work with humans, and pilot studies of safety and efficacy. And a real study is a randomized controlled clinical trial where you have some patients who receive the study treatment and others who receive no treatment, or what we call sham treatment. And that's really the only way we can tell if a treatment is appropriate and safe and effective. So I just want to give my recipe for research and some of what I've learned over the last decade or so in my research. I've made a lot of clinical observations over time as I've taken care of thousands of patients, and mixed with a little curiosity and lots of perseverance, and trying to plan and have good study design, whether it's clinical research or basic science. And then sprinkle that with some funding along the way, which has become more and more difficult from our federal government, and a little bit more perseverance, and a lot of serendipity sometimes. You got to be lucky, you got to be fortunate and put it all together. But I always say, as my mentor wisely said, data is data. And I'm going to share a little bit of that with you, and then how we're trying to explain that as we've gone through all these steps. And we have been very fortunate along the way to come up with some interesting observations. So about close to 15 years ago now, we started measuring oxygen levels in the eye. And I won't get into all the details by any means here, but it's important who you know and who you talk to, and how you interact with your colleagues, you can pick up little ideas in other specialties. And this was actually from a retina colleague, and we were looking at why some people develop glaucoma after certain retinal procedures. And so we used a little probe here. This is me with the mask. This is me without the mask. It's kind of strange to be without a mask for all this time right now. But we put a little probe inside the eye during cataract and or glaucoma surgery and measured oxygen levels. And you can actually see on this screen the oxygen level drop as we put the probe into the eye and measured the levels inside the eye. So outside the eye, the levels are very high in the environment, in the room, in the operating room, and the levels drop significantly as we measure inside the eye. There's actually a gradient as the oxygen crosses the cornea and very, very low levels around the lens of the eye. And serendipitously, we analyzed racial differences. This was not the target of our study. This is not what we went in to look for, but we identified differences between Caucasians and African Americans in this study. And there were lower levels of oxygen at each of the locations that we measured in Caucasians versus African Americans. So we tried to think, data is data, but why? Why would those levels be different? And how might this relate to risk of glaucoma? Well, there's little, what we call organelles, little tiny organs within cells called mitochondria. And these are the powerhouses of cells. They make the energy in the cell, but they also make byproducts that may damage cells. You've heard of antioxidants like blueberries, and those are supposed to fight some of these byproducts that lead to oxidative stress damage in the cells. And there's lots of different, the question is whether different races have different ways of processing oxygen, and could this lead to the risk of glaucoma? Again, data is data. So we started to search, and we started to search in the trabecular meshwork and studying how the genes are expressed and how proteins are made in this tissue. And we're now identifying differences, not only in patients with glaucoma, but certain racial differences as well. And hopefully someday this will lead us to develop strategies for new targets and a more personalized approach to therapy for glaucoma. I want to get back to my case presentation. You remember the 58-year-old woman who had advanced glaucoma in both eyes, uncontrolled pressures. Well, we started her on drops. We actually put her on several drops initially. And she came back a short time later. Her pressures were 24 in the right eye and 17 in the left. Much improved, but not low enough, not low enough for someone who has advanced damage. So she underwent surgery, filtering surgery in her right eye, and about 6 months later in her left eye. And her pressures have been beautifully controlled, around 10 in both eyes. So we call that a success in glaucoma. But the bigger success is that was 21 years ago. And this woman is now 79 years old. She's had fairly stable visual fields and central vision. We have identified several other family members with glaucoma, and she went to her grandson's wedding and looks forward to seeing her great-grandchildren someday. So it's not always a win like that. Glaucoma is a very important public health issue. No symptoms, comprehensive eye exams are the best way to screen for this condition. Be aware of family history and other risk factors. There's no cure, but we have many treatment options. Early diagnosis is important, and hopefully research will continue to yield breakthroughs in diagnosis and treatment. I thank you very much for your attention and welcome more questions.
Well, thank you, Dr. Siegfried. That was incredibly insightful. And I know a lot of people really enjoyed hearing your expertise, and we definitely do have some questions in the queue. So I will start with a few of these, and we'll get through as many of these as we can in the remaining 15 minutes. So one question just about treatment. Daily drops are widely used to lower pressure. How do these work?
Great question. So there's several different types of drops. There are some drops that work to lower pressure by decreasing the amount of fluid that the eye makes. So they target those cells that make the fluid. And the other mechanism is to increase the outflow. So it targets that trabecular meshwork and either alters it chemically, or even now there's some newer medications that alter it mechanically as well and alter that structure. There's in that trabecular meshwork, there are parts of cells that contract and expand, and it improves the outflow by some contraction in those cells and helping the fluid flow through.
There are a handful of them that relate all to, and I ask questions about the interplay between cataracts and glaucoma, and whether cataract surgery has an impact or whether cataract surgery is even possible after surgery for glaucoma.
So I'll take the first half of that first. What is the relationship between cataracts and glaucoma? And I will say this has been studied more in depth over the past decade or so. And we have always seen that, or we have often seen that removing a cataract can lower pressure. This is very clearly shown in the study, the ocular hypertension treatment study, which was based here in St. Louis. The principal investigator for that study, Michael Cass, is here at Washington University and led this study looking at patients who had elevated pressure but did not have damage from glaucoma, ocular hypertension. And in looking at those patients that had an average pressure of around 24, this was not part of the original trial, but it was a follow-up looking at those who ended up having cataract surgery. And indeed, there was significant lowering of eye pressure in those who had cataract surgery. And the higher the pressure is, actually, the more impact cataract surgery has. So that's one connection that we definitely understand now about cataract surgery. How long that lasts, and is it a long-term treatment for glaucoma, that is unclear. And I often talk about it being a honeymoon period for a few years. However, as I mentioned in angle closure glaucoma, the lens is a very, very important factor in causing the compression of that area. And so removing the lens is actually a very important therapy for angle closure glaucoma, and may be all that one needs if there is not significant damage. The other part of the question was, can you have cataract surgery after glaucoma surgery? And the answer is yes. It is true that cataract surgery after a trabeculectomy procedure or any filtering procedure can incite some inflammation, and that inflammation may decrease the function of the filtering procedure. However, with modern techniques of cataract extraction, we definitely have improved our success rate, and it is absolutely not a contraindication to cataract surgery.
Terrific, thank you. We have a question here as well. How effective is marijuana for patients with glaucoma?
So I hear this question a lot, especially as medical marijuana is now approved here. And it is true that cannabinoids lower intraocular pressure. However, they are not very effective, not nearly as effective as our standard topical medications or laser or other procedures. And the duration of action of the chemical, the cannabinoids within marijuana is not very long, perhaps 2 hours. So it would be very difficult for one to live their life having minimal effect on eye pressure and having to intake the marijuana in some way, shape, or form every 2 hours. So I do not recommend marijuana for this condition, but I believe that there are some conditions where it may be appropriate.
Thank you. One question that's interesting as far as monitoring the progression of glaucoma, the question is specifically on the peripheral vision test. I know that it shows the darkness in the if a patient has suffered a stroke. So how can you see the glaucoma progressing if this shows as well?
So that is true. The key is the pattern of damage. So in a stroke, we see that the defects respect the vertical midline. They go up and down. And you notice that on the visual fields that I showed in my presentation, they actually respected the horizontal midline. In other words, it was above or below those arc defects. Now, if the glaucoma defect is in the same location as the stroke, then it is true. One cannot completely evaluate the visual field, and one has to look at other parameters as well. So that's a great question.
Another question, are there any therapies to help reverse visual changes associated with glaucoma?
No, I wish that there were, but there are not. Once the damage has occurred, it is not reversible.
Another
But
one,
maybe someday when we have stem cell therapy for regeneration of the optic nerve.
exactly. What is the impact of dry eyes on glaucoma?
Well, dry eyes don't really impact glaucoma. So there's two separate areas that are dry or wet. So a lot of people ask, I'm tearing or I have surface issues, and that they're not connected in any way, shape, or form. However, the medications that we use often cause surface problems on the cornea and symptoms that are consistent with dry eye. And that is a chronic issue with our patients who are taking long-term medications, topical medications.
Terrific. Another question is there any relationship between glaucoma and branch veining occlusion?
So branch retinal vein occlusion is a condition where there has been basically a stroke, a small stroke in one of the blood vessels in the retina, a small branch of the retinal vein. And that can cause a lack of oxygen in that area. And so the retina fights back by forming new blood vessels. The problem is that those blood vessels are not normal, and they can grow, and you usually see this more in a larger occlusion called a central retinal vein occlusion. And those abnormal blood vessels can grow in the area of the drain of the eye and cause what's called neovascular glaucoma. And that those abnormal blood vessels can bleed and can also cause scarring in the drain of the eye, and that can lead to glaucoma.
Terrific. We have an interesting question about the anatomy of the eye. Does a thickened sclera increase pressure?
Well, we do see that there are people who have, so the answer as a general term is no, but those patients are oftentimes have a smaller eye and can be at risk for angle closure. But in and of itself, a thickened sclera does not cause glaucoma.
And here's one just as a general preventative medicine type of question. Are there things you can do to help keep from getting glaucoma?
Have periodic eye exams, comprehensive eye exams. You want to catch it at an early stage. But in terms of diet, environment, exercise, dietary supplements, no. We do not have any evidence to support the use of antioxidants. We don't have the evidence, as in macular degeneration, to use certain vitamins and supplements. No.
We've had a couple of questions come in that are effectively the same thing. And the gist of it is, are there any current methods of monitoring intraocular pressures at home? Or are there any possible self-monitoring devices on the horizon?
So COVID has really made us think a lot about telemedicine in all of medicine, including ophthalmology and glaucoma. And there are devices that can be utilized. There's something called an eye care. Also a tono pen can be used by an individual. One does require training. And I think someday we will get to that point where we will do more home monitoring. We're just not quite set up for that yet. It is costly. It's very costly. But we may get to the point where we will allow patients to borrow these devices for a period of time. But at this point, the technology, although it exists, that there are some devices that people can use on their own, it does require training to be safe and accurate.
Terrific.
There are also, I'll just mention, some online visual field tests and online vision tests that are out there, and we're getting closer to that, but nothing beats a live exam still.
Terrific. Another question. Is there a relationship between loss of contrast vision and glaucoma?
So contrast sensitivity absolutely is affected in glaucoma or any other disease of the optic nerve. We also see loss of contrast sensitivity with other conditions, but yes, in glaucoma, the contrast of black and white and gray is very important. It is a finding. It's not something that we routinely test for in the office, but we definitely counsel patients on those findings.
So a generalized question that may need more information, but I think it's interesting. If a patient also wears glasses, is it recommended that LASIK surgery be performed on patients that have glaucoma as well?
So it depends. If they have very advanced glaucoma, I would push against performing LASIK surgery because of the procedure requires an elevation of pressure to perform the flap formation, and so I would not recommend that. There are other forms of refractive surgery that may be safer, but anyone with advanced disease probably should not undergo refractive surgery.
Terrific. I think we have time for a couple of more questions. I'll go with this one here about the diode laser surgery. Could you please explain the advantage of diode laser?
So diode laser is a procedure treatment that I did not go into. Diode laser is performed nowadays with a probe on the surface of the eye, and the laser energy is absorbed through the outer coat of the eye, the sclera, and it treats the ciliary body, the epithelium, the cells of the ciliary body that make the fluid. And by doing so, it turns off the faucet, turns down the faucet, and less fluid is made. So you get to the source of the fluid rather than the outflow. So the inflow is decreased with a diode laser. Usually diode laser is reserved for people who have very advanced disease and have had multiple procedures and are not a good candidate for further surgery, or in certain conditions where if there is poor central vision, and again, that other types of surgeries are not indicated.
Terrific. One final question, and there's multiple people have asked this. Is there a correlation between hypertension and elevated eye pressures?
Not specifically, no. And people always ask in the office, oh, I'm nervous, my blood pressure's up, I think my eye pressure is going to be up. And there is not the same correlation with anxiety or even high blood pressure in general. There are some studies that correlate the two, but it's not, people who have high blood pressure also have other conditions as well. And so no, there is not a direct correlation at all between high eye pressure and high blood pressure.
Terrific. Well, thank you so much for making time, Dr. Siegfried, to share this information with everyone. And thank everyone who's in the audience for attending tonight. We really do appreciate you taking time to be with us this evening. And thank you for all the questions. There are several that are still in the queue, and we will be following up with all that we can after the event. Thank you, and have a great rest of your evening.
Thank you.